Today I'm going to talk about health literacy and opportunity for better outcomes for all. So just to give you an overview of my talk today, I'm going to give you a Health Literacy 101, so what health literacy is and why it matters, and thank you to Rachel who's already covered much of that material, so I'll go through that quickly. I want to give an example of why health literacy matters, a relevant one which relates to some recent work I've been doing in COVID-19 and health literacy. And then I lastly want to talk about what we can learn from health literacy research about how to communicate more effectively to our community. So first, Health Literacy 101. So health literacy is the cognitive and social skills which determine the motivation and ability of individuals to gain access to understand and to use information in ways that promote and maintain good health. And importantly, it means more than being able to read pamphlets. By improving a person's access to health information, their capacity to use it effectively, health literacy is critical to empowerment. And it's important to note that health literacy is content and context specific. So even when a person has advanced literacy skills, their ability to obtain, understand, and apply health information in a particular context can be poor. I like this model of health literacy, which shows 3 levels of skills that you need to be health literate and function effectively in a healthcare setting. So at the base is functional health literacy, and these are the reading, writing, numeracy, and oral skills that we traditionally associate with literacy. The next level is called communicative and interactive health literacy, and these are seen as more advanced cognitive and social skills which people need to be able to communicate about their health and explain their symptoms and negotiate with healthcare providers. And then at the top is described as critical health literacy, and this is seen as the most advanced health literacy skill, and it's the ability to analyse and then act on information. And all these 3 levels are seen as crucial to becoming a health literate person. Oops, sorry, I've gone the wrong way. But health literacy is not only made up of an individual's literacy skills and capacities, like those I just showed you in the previous slide. It's also affected by the demand placed on the individual by the environment. Now, we know from Australian Bureau of Statistics data that a high proportion of the population have inadequate or lower health literacy, lower than would be desirable. So data collected in 2006, which is the most recent performance-based assessment of health literacy in Australia, showed that 59% of people had inadequate health literacy, and that lower health literacy was associated with lower levels of education, a language other than English spoken at home, being from Aboriginal or Torres Strait Islander backgrounds, and being older age, as well as other factors. We also know that the health literacy environment is too demanding for most consumers, and there's a whole raft of research which has analysed the demand placed on the individual by the health information environment, and that shows that between 60 and 95% of health information that is provided to consumers and patients is too complex for people with lower literacy. So we have a real problem here. We have a high proportion of people who have suboptimal health literacy skills, and we have an health information environment or health literacy environment that is not suitable for them, that is too complex. This slide gives a bit more detail into the models I've just shown you. I think on the left describes health literacy and gives the different levels of health literacy that I talked about, but also includes, brings in the idea that stress, fatigue, also illness in this orange arrow here, can also strongly influence a person's skills and ability at any given time to understand and act on health information. It also gives a broader range of factors in the health literacy environment that affect the demands and complexities of that environment, and that includes the healthcare system, how it's structured, financial resources, the social supports that are available, and of course the health resources, so the health information that's around. So why does health literacy matter? Well, we know that low health literacy is associated with poor health independently of all other known risk factors. So low health literacy is associated with higher rates of chronic disease, higher rates of mortality, higher hospitalisation rates and use of emergency services, lower rates of preventative services such as screening, poorer self-management skills, greater medication errors, lower levels of knowledge about disease, and lower ratings of satisfaction with doctor-patient communication. And this has been well summarised in several systematic reviews. We also know that health literacy costs billions. And from research conducted in the UK, it accounts for between 3 to 5% of all healthcare costs. So that's estimated to be 2.8 to 5 billion pounds per year. We know in Australia there are increased out-of-pocket costs for people with lower literacy. And we also know, of course, that the cost to health and quality of life is huge. So I now want to switch to an example of some work that I've been doing in relation to COVID-19 and health literacy to show you really another example of why health literacy matters. So this work originated from concerns early on that much of the prominent state and national public communication and messaging around COVID-19 was not designed for a diverse and hard to reach and low literacy audience. And myself, Jan Donovan from Consumers Health Forum, Danielle Muscat wrote about this in late March, early April, and we published it in Croaky. And it's since been, and others have since commented on this and also noted that, made the same points publicly. So what we could see from then, and we still continue to see, is much information presented on COVID was online, it was static or web-based content, and was written at a level too complex for even average readers. And this has since been shown in a nice paper by Mishra et al. Recently published, which compares the readability of official public health information about COVID from websites and documents around the world, including in Australia. And it seems that the health literacy skills of the community are not being well considered in the information provided about COVID-19. We also know that there have been problems with translated government communication resources, and those that were available may have been underutilised. And this seems to have resulted in people finding other non-government resources to fill the gaps in understanding. And this, for migrants particularly, has included information from their home countries, which may not be relevant to life in Australia. So in April, we launched the Shell, so that's the Sydney Health Literacy Lab COVID survey. It's a survey of knowledge, attitudes and behaviours. On COVID, we used an online survey methodology, and I've listed all of the team members on this project. And what we did was we recruited people online and via social media. And we had a baseline survey which had over 4,000 participants, and then we've run further monthly waves of the survey to follow a subset recruited by social media. We've had over 1,000 responses to each survey. I should note before I go on and tell you what we found, that we have some limitations to our survey. We had to create it very rapidly. We had no funding, so our sample is limited. It's not nationally representative. We recruited people online, and our measure of cultural and linguistic diversity is limited to primary language other than English spoken at home. So there are some important limitations to this work, but I think it shows some important findings. So to cut to the chase, what our survey showed, so these are the results first of our baseline survey, which was carried out in the middle of April with over 4,000 respondents, was that people with lower health literacy and those who spoke a language other than English at home had poorer understanding of COVID symptoms, were less able to identify behaviours to prevent infection, and experienced more difficulty finding information about COVID-19. People with lower health literacy, and again, those who spoke a language other than English at home, were also more likely to rate social distancing as less important. And they were also more likely to endorse misinformation and conspiracy beliefs about COVID-19 and vaccination. So then, in our next piece of work, we analysed data from 3 surveys, so from the May and June survey, as well as our baseline April survey. And we looked at support of misinformation and how that had changed over time, or looked at the associations over time. What we found in that analysis was stronger agreement with misinformation, still associated with health literacy and language other than English spoken at home, was also associated with younger age, a male gender and low education. And we also found that misinformation beliefs were associated with lower digital health literacy, so that's the skills and capacity to search for online health information, lower perceived threat of COVID-19, lower confidence in government, and lower trust in scientific institutions. So in summary, what we see from this work is that there are important disparities in knowledge, attitudes, and behavioural responses by health literacy and language spoken at home, and as well as other risk groups such as young people. Worryingly, we see endorsement of misinformation beliefs consistently reported over 3 months, and again associated with health literacy, language spoken at home, as well as education, gender, and younger age. And this corresponds with public health communication gaps about COVID-19 that we raised and others have raised really quite early on in the campaign. This is concerning because it does have potential to undermine efforts to reduce viral transmission. It may lead to social inequalities in health outcomes in Australia, and we have seen inequalities in health outcomes in the US and in the UK that have been carefully documented. But I note there are limitations to this work. It's not nationally representative. And our sample of participants who spoke a language other than English, is small. But we need more work in this area. And we're now working with the Western Sydney LHD Multicultural Health Service to extend our survey to people with from culturally and linguistic backgrounds. So we hope to have more data to present from this group soon. But so I think that gives a nice example of why health literacy matters and why it affects us all, in fact. But what can we do about it? This is the crucial thing. And what can we learn from health literacy research about how to communicate more effectively? Well, actually, we can learn a lot. There's a lot we can do. It feels like we're doing this, we do this a lot, and it feels like we're doing this with COVID-19. But really, we can do many things, and I want to tell you about some of them. So this slide gives you a summary of what I'm going to go through relatively quickly. So we can use evidence-based interventions that work, and all of these hexagons represent bodies of work where we have shown improvements in outcomes for people with low health literacy. So that includes written health information, prescription drug labels, verbal communication, risk communication, shared decision-making, and engagement with the education sector. So improving written health information. We know that use of plain language improves understanding. That has been well shown. We can avoid jargon words. You see this website here, it's a list of medical words that have a replacement with a much simpler version or everyday word, which is incredibly useful and we should be using in all our health communication. We should avoid words with 4 or more syllables. We should write text at grade 5 reading level. So that's written for an aged 11-year-old. We should use simple font, Arial or sans serif, and we should avoid capitals. We should use lots of white space. We should break up text and have a strong contrast between the text and the background. We should have 3 to 5 main points maximum per document. We should put essential information first. And what we do know from the literature is that if people find text easy to read, they're more willing to comply with the behavioural advice. and they're more likely to judge the information and source of that information favourably. So it matters how we present our information. We also need to pay attention to images. They must, of course, be culturally appropriate, and they also need to be interpretable without text. I want to give you some example here. Here's an image on the left, which is about eating a piece of meat that's the size of your palm. Now, this is relatively easy to interpret from the visual. Now, the image on the right is about eating low-salt foods, avoiding low-salt foods. But how would you know whether you were to eat or to avoid those foods? And of course, they're very culturally specific as well. We can also improve communication of numeric health information. Again, there's a nice body of work which shows that presenting numeric information in tables or pictographs, not text, helps understanding. Presenting numeric information in a logical order for evaluation, so the higher number being better, for example. Presenting information with a consistent denominator, using natural frequencies such as 1 out of 100, or simple percents such as 1% to help people understand risks and benefits. Avoiding decimal places and rounding to base 10 if that's appropriate. Also, adding video to verbal narratives helps. There's also an excellent body of work from prescription drug labels, which is about making content actionable and instructions clear and precise. And what this body of work shows is that if instructions are precise and explicit, drug label errors reduce. And in this study, they reduced from 50% to 11% in a low literacy population. And so in that study, they changed the instructions from those on the right under the red cross, which said take twice daily or take every 12 hours. They changed them to take one at 6 p.m. and one at 6 a.m. and one at 6 p.m. every day, or take one with breakfast and one with dinner. And they showed that level of reduction in drug label errors, which is impressive. In terms of verbal communication, we can use teachback. We know that patients remember and understand less than 50% of what clinicians say in reviews that have looked at this. Teachback is a method where a healthcare provider asks patients to explain in their own words what they need to know or do in a caring way at the end of the consultation or interaction. It's very important to make sure that it's asked in a caring way and is not asked in a way to test the patient, but more asked in a way to test the skills of the healthcare provider's communication. But we know in research, and some of our own research has shown that using teachback improves patients' or consumers' understanding of what steps they need to follow, and also that it can improve their trust in the advice that's been given. In terms of communicating risk, we know that we can use formats that improve understanding. So on the left, I've got an example of a pictograph where we're showing 5 out of 100 women will experience side effects, or 5%. We know this format is better understood than if you use pie charts or bar charts or relative risk formats. And we also know now that there's good evidence that shared decision-making can improve outcomes for patients. That means improving patients' knowledge, their risk perceptions, reducing uncertainty, increasing participation in decision-making, can lead to more positive doctor-patient communication. And in fact, research also shows that the impact may be greatest in lower literacy and socially disadvantaged patients. And finally, in terms of the evidence of what can work, we know that we can engage with the education sector. There's again now a body of work which shows that health literacy programs, some conducted in Australia that I've been involved in, there have been others in the UK and others in the US, now show that you can improve health literacy in the community among people with lower basic literacy and numeracy skills. There's also some excellent work in schools which shows that you can teach children, and this study by Nasangi was conducted in Tanzania. You can teach school children skills in numeracy and health literacy that they can carry with them. So as I draw to a close, I wanted to bring up here, I'm coming back to COVID-19 now because it's such a, we're all facing this every day, I think. And I recently took my son to be tested for COVID, and I had to have a test too. And I was given this leaflet by New South Wales Health. And I don't want to single out New South Wales Health for bad behaviour, because, you know, it's similar to other documents produced all over Australia and in many places of the world, actually. But I just wanted to put it up and say, you know, thinking about the advice I just talked about and what we can do to improve information, what improvements could we make to this document if we followed health literacy advice? I suggest that we could make many, many improvements. And I just want to give you some examples from the WHO, where perhaps out of all of the organisations seem to be applying health literacy principles a bit better than other organisations. And I ask you, you know, if you're stressed and tired and got a child screaming in your ear, which document would you rather read? You know, these or the ones before? I know which I'd rather read. But now, just in my closing, as I went through, there is lots of evidence. There are lots of things that we can do to improve the way we communicate to the community and to patients, to improve understanding and to enhance the equity of access to health information. But we now face an added challenge, and this is a challenge we are less prepared for. We face the challenge of YouTube, Instagram, TikTok, social media, and the online world. And this is where we need to invest our resources and our attention to working out how we can better communicate health information to our young people who rely on these sources of information. And we've seen that, as I talked about, the misinformation in COVID and how that is prevalent in younger age groups. We know that's because they're getting their information from these sources, and it's very hard to distinguish good quality information from poor quality information. So this is a challenge for us, but I feel like we should at least be able to apply the principles that we know to the content that we can to take us forward to improve everyone's health literacy. And it feels like good health literacy has never been so important. So with that, I think I'll finish, and happy to take any questions from anybody.